Zoom can hear me well. Say the same thing for the slide sharing. I can see my slides are shared on the Corvallis page, and I presume everything is going fine on the Zoom. If somebody on the Zoom can give me just a gesture that they can see my slides. All right, thank you so much. Now, good afternoon. Last week of the term, it's week 10 already. You had your exam, I think, last week. I hope you all did well. Not last week, the week before. No, it was actually last week. I hope you all did well. This is the first lecture of the finals, I think, of the final materials, or the first week of the for the final materials. I do know that I do note, and I noticed that from Dr. Ishmael, and we have this kind of approach that Dr. Ishmael provides you, the cluster and the migraine headaches, focuses more on the epidemiology, the pathophysiology, especially with related to CGRP, and the effects of, symptomology. My part of the headache therapeutics is mostly about management. So I will have some introduction in the beginning, just as a kind of a summary of what is migraine headache, what is cluster headache. But in terms of treatment, I'm going to jump forward on what to, and I expect you to have some basic idea about migraine pathophysiology. The lecture, as you see, it's not very big. It's 40 slides. I like my therapeutics to be straightforward and not too much complicated for you. And as always, we're going to have a lot of time for discussion. So please, you can ask me any time. Now, the first thing I will be talking about today is migraine headaches. As you know, it is the second most common type of headache, of course, after tension headache. We didn't talk about tension headache. This is more of a covered in the P1 year and as part of the with mostly non-prescription medications. But migraine headache is the second most common type and is the most common cause for emergency admission from a headache. As you know, migraine headache is a unique in its presentation. What makes it remarkable is the unilaterality. So only half the brain, or only half, but only it's a single hemispheric involvement, and the quality of the pain is very noticeable. Is that you see patients coming from, it's a pulsatile, throbbing, vascular kind of pain. We feel that the blood is throbbing in the brain, and as you know, from pretty much by now, there's a lot of vasodilation and vasoconstriction in the pathophysiology. Is that in the initial phase, you will have some vasoconstriction, this followed by vasodilation. And that vasodilation is responsible for the release of the inflammatory mediator. Among them is CGRP, and this causes excitation of the trigeminal nerve. And the trigeminal nerve, as you know, it has 3 branches. It has the zygomatic, the mandibular, and I think the 4, and they all, and a damage to the trigeminal nerve will always be associated with severe facial pain. And that part of unilaterality will be associated with migraine headache. So it's a moderate to severe in quality, and that's the what comes after it. It's what makes the morbidity of migraine so big, is that it causes a patient to be kind of disengaged from carrying normal daily activities. As many of you know, you probably have, many of us maybe even have witnessed it at one point. It's a very common at young to early adulthood kind of age, most common associated. It's almost 3 times more common in females than males, very highly common in the childbearing age potentials, and we will have medications to talk about for prophylaxis. So pregnancy concerns is a big deal, especially if you have a patient taking a medication daily. So how does the headache present itself? It kind of presents itself in a sudden. It's usually there are a course of triggers, factors. I have my triggers in the next slide. So there are trigger factors, and usually a culmination of trigger factors with some increased stress and environmental factors will yield the attack. Once the attack happens, is usually more severe early on. However, the severity and the disability from it carry on for up to 72 hours. And the longer the attack, the more likely the more severe is likely to be the next attack. This attack is not just come in pain, but there are associated symptoms with pain. Almost 75% of patients having a migraine attack, and notice I'm saying attack because we're going to treat the attack, but then we're going to give different medication to prevent the recurrence. So migraine is a two modality treatment. But before I get to the treatment is I mentioned 75% of patients will have nausea and vomiting, will have very bad GI symptoms. I think you consider the effect of serotonin in the brain as much as I hope you consider the effect of serotonin in the GI tract as well. In fact, serotonin was discovered in the GI tract long before it was discovered in the brain. So, and that's no coincidence that many of our GI medication, the best nausea medication, Zofran or Dansetron, is a serotonin agent, and it works in between the brain and the gut. So, not to mention here is that this a lot of trying to associate some of the pathophysiology of that serotonin association with the pathophysiology with how much GI side complaints people, not side effects, sorry, with how much GI symptoms patients have with migraine headaches. Not just GI, as I mentioned, it's a trigeminal nerve involvement most likely, so you can have also always you're going to have some accompanying cranial symptoms. So you get photophobia, uh, sensitivity to light. So coincidence that migraine headaches occurs most often during the day, and light is among the triggering factors. Photophobia, sensitivity to light, and as you know, patients with migraine headaches, even during the attack, they'd like to have a calm, dark environment because of that effects of light. Overstimulation, really. Phonophobia, again, phonophobia means sensitivity to listening to sounds. So just like the patient will have hypersensitivity to light, patients can have also hypersensitivity to sounds. Patients can have a hypersensitivity to foods and have nausea and vomiting. And these are all common, and by far most common is nausea, vomiting associated with the pain. Now, it's not just the pain. Some sets of patients, around 30% of the migraine headache patients they will have an aura before the migraine attack. So an aura is a neurologic phenomena associated with hyperstimulation or hypostimulation of part of the brain, and it's usually precede a hyperactivity in the brain. We see auras before migraine, and there are auras before seizures as well. And we define the type of migraine, and as you later you will define the type of seizure, whether it is associated with aura or not associated with aura. Most likely with migraine, most migraines, what we call in the old nomenclature, the common migraines, most migraine doesn't have aura. Only 30% of patients will have aura. And what are these aura? It could be a mix of symptoms. Is usually sensory. It's a sensory and perception symptom. So you can get visual aura most likely. Patients often tell you that they see a pattern of zigzags. They see blind spots and a zigzag pattern. This is called the scatomas, like a blind spot. It's usually happens, overwhelm the patient. They persist for minutes, for 10 minutes, and then the attack happens. Or it could be sensory symptoms, sensory in terms of numbness and tingling. So you get some kind of neuropathies. Or it could be motor symptoms. And the motor symptoms mostly it's likely is going to be weakness, muscle weakness. Patient can't move, or aphasia. Patient have trouble speaking. These auras usually occur within, 5 minutes, maximum 10 minutes. It can go all the way up to an hour, and then the attack will happen after. It's usually stated that people who have migraine attack with aura are most likely to have stroke. This is just by observational studies. In general, migraine is associated with higher risk of stroke, but nothing out of direct causation here. So what are these triggers? So basically anything that can annoy the brain can trigger a migraine. And patient can have a migraine trigger from more of these. Now, if you look here, and I know I highlighted everything in red, it doesn't matter if it's highlighted or not. All of these, what I want you to consider here is try to understand the picture here. See sleep disturbances, dehydration, stress, emotional letdown, skipping meals. That almost sounds almost like any university student working hard jobs, or anybody who's pretty much working, supporting family. Anybody's going through a lot. Through these triggers are normal triggers, and people who are susceptible to have migraine will unfortunately be triggered by these, and that could cause a migraine attack. That's why it's no coincidence that migraine is most common disease of pretty much early adulthood. That's when the environment, basically life gets more difficult. And that's why it's very important to tell patients at risk of migraine or patients who are migrainists to, if they can control, for example, the emotional stuff, if they can control the stress from, school or from work, if that's not controllable, at least you can improve your sleep cycle. At least you can have meals regularly. Skipping meals and sleep disturbances and of course dehydration, are super, super key in, just in healthy lifestyle in general. But for migraine attack is very, very big deal. And people, I know for a fact is that skipping meals is a really, really big deal. Medications, mostly medication abuse or medication withdrawal can trigger a migraine in somebody who is already at risk of migraine. Other than medication withdrawal or abuse, vasodilator can trigger a migraine. So it goes no coincidence is that in the early phase of the migraine attack, there is a big vasodilation, and that's the serotonin that's we're going to stop. And that vasodilation impairs the vasculature, as well as responsible for distribution of inflammatory mediators. So vasodilating medication, basically nitroglycerin, patients who have heart attacks, they take nitrates. I'm not talking about vasodilation like an ACE inhibitor. That's not much of a, they are vasodilators, but they're not big, huge vasodilation like nitroglycerin or nitrate supplements, not supplements, sorry, nitrate sublinguals. Alcohol in all shapes of form, abuse or withdrawal can, weather changes, extreme cold, extreme hot, extreme dark, extreme humidity, all of these can affect. Smoking and smoking cessation can, in terms of nicotine withdrawal, of course. Strong perfumes, that's why in hospitals you don't put perfumes, not just for migraine, as well seizure, as well allergies, but strong perfumes in general with migraine. There's a lot of smell and taste. You see chocolate as well. Chocolate has theobromine. Theobromine is very strong vasodilator. Caffeine, cheeses are rich in terms of types of vasodilatory alkaloids. Hormonal changes, physical activities, loud noises, so much, everything, almost everything can trigger a migraine attack. Any insult to the brain, environmentally, dietary, can basically trigger a migraine attack. Now, treatment approach. See, I didn't have much introduction about migraine. I'd like to go straight forward to treatment. I think the picture is known. The migraine symptomology is well understood. You know the prevalence of migraine and the female predominance. The symptoms is understood from the symptomology. Now I will go with the treatment. So for treatment, we have two modalities. There is the abortive therapy. So that's the medications that you're going to use in the pain phase of the attack. And theoretically, you should only use it to abort. That's why an attack should never be used long term as a daily scheduled medication. It's always an as needed basis. And then there is the preventive therapy. That's where you're going to use it scheduled, and it's going to be offered to patients. Not every patient will have migraine prevention, but there are some that you want to give migraine prevention. And just think about it. Who do you think will be a patient worth to talk about, to consider taking a medication every day? Remember, at such young age, we're talking relatively to take a medication almost every day for years. Is that not everybody but those with more than 15 days headache per month. I'm not saying 15 days headache day by after day for 15 days of the month. The first 15 days the patient is having a continuous migraine headache. That's not the case. I'm saying cumulatively the patients will have frequent attacks. Now the guidelines tell you more than 15 days of headaches per month. Doesn't have to be every day by day after day. Logic tells you anyone who has a recurrent, basically. If a patients have a migrainous attack, they get treated, they come, they have, a month later, they had another attack. At this point, you're not going to say, no, wait until you will have 15 days attack per month so I can give you prophylaxis. It's going to be offered for the patient, and it's up to patient to decide if they want to. Also, it's not just quantity, it's the quality of pain will make you consider the preventive therapy. Is patients with severe attack, it's unethical to deny them preventive therapy just because they did not have a recurrence yet. Any patient with a severe migraine attack are somehow candidates to receive preventive therapies. And of course, it goes without saying that patients who cannot tolerate the abortive therapies or those who have contraindications to the abortive therapies, and there are big contraindications, big patient population will not be considered. They will have to have preventive therapy because that's their only way to prevent an attack in which the abortive agent is contraindicated for some reason. For abortive therapy, I just wanted to mention that, of course, because we said there is so much GI involvement with the onset of attack, most approaches here, we're going to try to give IV parenteral medications. There are orals for mild symptoms, but in terms of hospital admission from a migraine, we're talking most likely we're gonna talk about parenteral route. So nasal, intramuscular, intravenous, subcutaneous. You try to avoid the oral route as much as possible, especially for severe attacks. So what are the first line agents? Now for abortive treatment, now I'm sure you studied this with Dr. Ishmael, the triptan medications, these are selective 1B, 1D agonist. I don't care if you know what's you should know selective 1B and 1D agonist. The board cares about them. And the idea of this is that these are serotonergic drugs, have very short half-life. They come to the brain, they have very high lipophilicity, they can come to the brain really quick and activate these 1D, 1B serotonergic receptor. The activation of these serotonin, 5-HT, 5-hydroxytryptamine, that's serotonin, the activation of these receptors will cause some vasoconstriction. Now, the old theory in the pathophysiology of migraine is that the story ended here, is that migraine was a vasodilation in nature, and that vasoconstriction will treat it, and that was the approach. It wasn't thought at that time, the CGRP, the role of the inflammatory mediator, it was morely thought of a vascular response rather than an inflammatory response. Nevertheless, triptans does well, they do this vasoconstriction, but it's not only the vasoconstriction, is that they also inhibit the release of vasoactive peptides like CGRP, calcitonin gene-related peptides. These vasoactive peptides are what's thought to be responsible for this vasodilation. And of course, that will block pathways, down the line. It will block the pain pathway and should abort the migraine attack. And these drugs works really good. I talked about GI side effects. So our goal here, our agent of choice we'll try not to have something GI. So it's important to know how these medications are available. So all these medications are available as oral tablets. So they can be all given as oral tablets or capsules. And they will be offered for patients for self-treatment for mild to moderate symptoms without nausea and vomitings. However, for those who have nausea and vomitings, and they are majority of those who come to the ED from a migraine attack, you can't give them the oral. So you're going to have to think of alternative. And for alternatives, it exists only for 3 triptans. So we have, I think, 6 triptans. All of them are in capsule. 3 of them are available not just only in capsule, they're available in different routes. So as ODT, as oral dispersible tablet, it's rizatriptan and zolmitriptan. Notice the Z. The Z is good. And so rizatriptan and zolmitriptan are the two triptans with a Z, and I think you should associate that with ODT. I think nowadays they're becoming generic, so they're having more ODTs, but this is most important. For nasal, we have sumatriptan and zolmitriptan. They are a nasal spray, and for subcutaneous, only sumatriptan is available. There are no IVs, there is no intramuscular, there is no topical. They're all tablets, except sumatriptan is also available as nasal and also available as subcutaneous. And sumatriptan is the first triptan available in the market, and it goes with. Therefore, it's no coincidence it will have the most. It is the most studied. It is the most commonly used, and it is associated. It has the most dosage forms. I have a table now. Now, this table is all the triptans that we have. You see naratriptan, alotriptan, forovatriptan, sumatriptan, Maxalt, which is rizatriptan, elatriptan, and there are some sumatriptan naproxen combination associated with NSAIDs, and there is zolmitriptan. So notice sumatriptan, they're all oral, but notice sumatriptan. I really want you to consider this. It's available oral and nasal spray, and is the only one also available as a sub-Q injection. It's a needle-free delivery. So the patient, it's kind of a create a vacuum of pressure on the skin, and the drug will diffuse through. It's very cool. It's very expensive. So it's a needle-free injection, auto injector. And you notice the onsets of actions. Now, I don't want you to memorize, but I want you to take something from here. All of these drugs should have a very quick onset. So every drug here has like a within 10 minutes to an hour. However, you see there are some issues, some kinetic issues between triptans, and it's very important. Pharmacist has to know this. Of all the triptans, naratriptan and frovatriptan, this one I highlighted in red, share something important that other triptans don't have, that they are somehow almost 50% renally eliminated. That renal elimination of frovatriptan and naratriptan make them the longest, give them the longest half-life, give them the longest duration of action, and give them the lowest onset of action. So these agents are not ideal for your patients with acute attack migraines on all cases except one thing. The only cases these two drugs are preferable to the traditional sumatriptan, almotriptan, zolmitriptan, which all have quick onset of action. Notice it's not just they have renal metabolism. Notice what they don't have compared to the others. They don't have MAO metabolism, monoamine oxidase. That MAO, monoamine oxidase, we have MAO inhibitors. As you know, these are antidepressants. That's the same MAO. So these medications, triptans, are serotonergic drugs, which, and by virtue of MAO inhibition or MAO metabolism, makes them at risk of serotonin syndrome when you combine them with other serotonergic medications. Technically, all of triptans have a blanket statement of a warning to avoid combination with SSRI, with SNRI, with dextromethorphan, with pretty much any medication is serotonergic medication. Now, if you want to be, now that's the blanket statement. The smart pharmacist will know that it's not generally all triptan. It's basically based on what the kinetics here is. I can tell you that frovatriptan and naratriptan don't have MAO metabolism. They're still serotonergic drugs. But I'm saying that these, the N and the F, nara and frova, have less likelihood to have serotonin syndrome compared to the other triptans. Now, the good pharmacist will know this between triptans. Now, the best pharmacist who reads evidence will read and find that all triptans are the same, and that the fact that there are risk of serotonin syndrome is extremely, extremely rare if it ever happens. Therefore, and this is tough because it's the case in neurology, You're going to see a contraindication for triptans never to be combined with antidepressant. But imagine how many depressive patients take their, um, sertraline or paroxetine or fluoxetine, and they have a migraine and now they need abortive. Plus, it's abortive therapy. You're taking only one dose of the triptan. So, yes, the FDA does say it's contraindicated to combine it or avoid combination as more as possible. Yet, evidence-wise, no triptan or the association of triptans or this real side effect or drug interaction is very rare. And if you want to be more cautious, then I would say use your kinetics knowledge and consider frovatriptan and naratriptan as the triptans of choice for patients taking serotonergic medications out of virtue that they don't have MAO metabolism. So from this slide, it's very important. I want you to know the differences between naratriptan and frovatriptan, how the renal and the MAO metabolism with the other triptans. And also I want you to look at sumatriptan and zolmitriptan and notice the nasal spray in addition to the oral tablets, which all of them has. So yes, as drug interaction, it is SSRIs, SNRIs, MAO inhibitors, other serotonergic drugs, so not just antidepressants. I'm talking about something like dextromethorphan, which is an antitussive, tramadol, which is an opioid with serotonergic properties, meperidine, which is an opioid with a serotonergic properties. All of these have risk of serotonin syndrome in combination with triptans. However, it's really this is based on just serotonin plus serotonin equals serotonin syndrome. On evidence, this is very rare, and it should always have a risk discussion, a risk benefit discussion before saying it's completely contraindicated to go to use it with others. Now, what is almost completely indicated is a different thing. So coronary artery disease, complicated coronary artery disease, complicated strokes, uncontrolled hypertension, severe peripheral artery disease, all of these, severe cardiovascular disease, atherosclerotic cardiac disease are contraindications to triptans because of that vasoconstriction. So that vasoconstriction that triptan does for not just the cerebral vasculature, it can also cause coronary artery vasoconstriction. And if you constrict the coronary artery to somebody who's uncontrolled hypertension, to severe stroke, severe CAD, to severe PAD, you may have a risk of exacerbation. So you avoid the triptans. And 2 years ago, you did not have any other options for these patients. Now we have options for CV patients as an abortive therapy. Other contraindications is pregnancy. Same vasculature. You don't want your placenta, the placenta where the fetal arteries and veins are connected with the maternal's artery and veins via the umbilical arteries and veins. Giving a triptans, these are lipophilic. They will cross the placenta. They will cause constriction. They will affect the vasculature, the maternal fetal vasculature, and they are contraindicated for pregnancy. They are also contraindicated from administration if they are to be administered within 24 hours from a drugs called ergot alkaloids. Actually, ergot alkaloids are the second line agents for migraine agents, so I'm going to talk about them. Ergot alkaloids are the older triptans. Think of it as tricyclic antidepressants and SSRIs. So SSRIs kind of a TCAs were first tricyclic antidepressants, and because they have so much side effects, we invented SSRIs. The same thing here between ergot alkaloids and triptans. It was in the beginning ergot alkaloids, and because of their side effects and their vasoconstriction that they do, we discovered the triptan. So triptan is the better version of ergots, and triptans and ergots should never be given within 24 hours of each other because of severe vasoconstriction. Now, as a general rule, you should not your patient should not be using triptans more than 10 days in a month. I mean, again, just like 15 days of headaches per month, this is 10 days of treatment per month, doesn't have to be a day by day. So if a patient is requiring triptans for more than 10 days a month, meaning that they're having more than 10 attacks per month, and that's absolutely should not be the goal. These medications should be used as short as possible because they can cause some kind of dependence. And this we call this medication overuse headache. And this is a paradox. So you give a medication for headache, and if you take so much of it, you get a headache from the medication that you give for the headache. So what's the treatment for that headache? Well, stop the medication causing the headache. And all abortive treatments, generally with migraine, only preventive therapies are day to day. All of these medications, as I mentioned, they are as needed. Now, you don't just give triptans, you give antiemetics with the triptans. Are we giving them for the nausea? Yes. Do they have pain analgesia effect? Yes. So antiemetic medications, if you don't have triptans, they can be given alone. They're not ideal, but if you have triptans, you always, preferably, you give it with an antiemetics. If you don't, you still give the antiemetics. These antiemetics are not your usual antiemetics. These antiemetics are dopamine antagonists. And for those of you in class or for those of you on Zoom, I think you can put on the chat, where did you some of this medication from? What are to what class the first two medications belong? Chlorpromazine, perchlorperazine. I'll give you about a second or so to think. Metoclopramide is a class by itself. We call it a prokinetic, but chlorpromazine and prochlorperazine, I'm sure you studied them and you know these medications, you were tested on them. Antipsychotics. Yes, thank you. And what generation of antipsychotics? First generation. Very good, very good. Now, if those who answered and remember that these are antipsychotics, you should consider the side effects and you should consider the fact, try to remember them as I go. So yes, these are the medications that you give here as antiemetics. Why they have antiemetics? Well, they're dopamine inhibitors. And what's the best thing to inhibit to have, we call these prokinetics. Prokinetics is a class of medications called for medication that will involve the peristalsis. The peristalsis is the contraction of the intestines, of how the food empties from the stomach to the rectum. The movement of that through the intestines goes through like a snake wave, and that snake wave movement called peristalsis, and they are inhibited by dopamine. So you give a dopamine inhibitor, you will have good peristalsis, and we call these prokinetic agents. So antipsychotics, first-gen antipsychotics, improve digestion through that, and metoclopramide is a pure D2 inhibitor in the GI tract. However, at high doses, it crosses to the brain and cause the side effects that antipsychotics cause. So metoclopramide is a fairly safe drug even for pregnancy, and these medications inhibit dopamine, improve peristalsis. We call them, they increase gastric emptying, so they improve the release of food from the stomach to the intestine, and that's why they're excellent nausea vomiting medication. A bit less efficacious than Zofran, which are the cancer nausea medications one. So these medications should be used in combination with triptans or ergot alkaloids because they have additive effect. And that additive effects, it's analgesia. So they can be as effective as triptan monotherapy for abortive therapy. So these medications are, and not just, and they are antiemetics, but they are preventing the migraine, treating the migraine attack as well. So, of course, parenteral, absolutely no oral here. You're giving an antiemetic. It doesn't make sense to give it orally. You have to give it parentally. You want it quick. You want it to quick. You don't get that analgesia effect from a tablet. You have to go parenteral, injectable. And when you give parenteral, you will have to give diphenhydramine as IV as well. IV diphenhydramine. For those who answered, why do we give or I think I wrote it here. Through what mechanism diphenhydramine is reducing dystonia? Maybe I should ask, what is dystonia? But I'm sure you studied this. So anticholinergic. Yes, yes, yes. Thank you, Philip. Uh, so dystonia. Those antipsychotic, first generation antipsychotics, they have no selectivity. They don't just block dopamine, they block histamine. So you have sedation. You block acetylcholine. You have anticholinergic side effects. You block alpha receptors, so you have orthostatic hypotension, and the blocking of the D2 receptors in areas other than the mesolimbic area will cause extrapyramidal side effects. That's what EPS stands for. And extrapyramidal side effects are mostly Parkinsonian-like group of symptoms. Dystonia is the most common, and dystonia means uh, uh, painful, spastic contraction of a skeletal muscle, mostly of the eyes and the neck. So the patient will have this, and we call this the oculogyric reflex. Patient will have an all of a sudden, as if they feel like they have been shocked by electricity, and they go like this. It's not seizure. It's dystonia. It's painful. It's pain. It's not like seizure and the patient lose consciousness. And you have to give anticholinergics here, and diphenhydramine is the drug to give. So when you give these antiemetics to patients, you have to have it is in the order to give 25 milligram, 12.5 milligrams IV diphenhydramine in addition to prevent that dystonia. So this is for all of them. Now for chlorpromazine and compazine, not metoclopramide, just these two. As I mentioned, these are first-gen antipsychotics, so they will have orthostatic hypotension. This is due to block alpha-1 blockade, and they will have QT prolongation. So if you give these medications, if you have a patients who have taking QT prolonging medications like fluconazole, like amiodarone, azithromycin, verapamil, atorvastatin, these medication may need to be put on a heart monitor to look for a QT prolongation. Of course, hypokalemia, hypomagnesemia, any bradycardia is a caution or even a contraindication to these. I have a question in the chat and says, can you use 5-HT3 antagonist for antiemetic? Yes, they use Zofran as antiemetics. They use it in the hospital, yet it doesn't, it's good for the nausea. It doesn't have that analgesia effect. It's kind of interesting. So they do use it. Per studies, low quality evidence show it works, but it doesn't work that it cause analgesia. And you don't want to use high dose of it because you're giving a sumatriptan, which is a serotonin agonist. It's a different serotonin receptor, yes, but that high dose, again, it doesn't really interact with the sumatriptan. But these medications, Zofran, they are given. I'm not saying they don't, but they don't produce the best often antiemetics as these. And oftentimes they're given with the compazine or so. But these antiemetics, the compazine is the one that has analgesia. So it's not just antiemetic, it has some analgesic effect, and it's good additive with the triptan. Now, generally, this is it. That should be a triptan and antiemetic. Now, if it didn't work, now we have second line agents. Now, the first second line agents are ergot alkaloids. They're not second line. I mean, triptans are preferred, but if triptans are unavailable for some reason, I'm not saying if they have contraindication, because those who have contraindications to triptans will have the same contraindication to ergots, because ergots are just a stronger triptan. So ergot alkaloids, these are parenteral, very potent vasoconstrictors. They have the same mechanism of action with the triptans, but they are more systemic. So they block almost every vascular. They block the vessels especially in your extremities. And one form of poisoning is called ergotism. with these medications, now this is poisoning, is that patient will have like a frostbite gangrenes because all they will have purple toes and purple fingers before they become fully ischemic. It may cause necrosis and become gangrene because of that severe vasoconstriction these drugs cause. So we have two medications of these. They're all, excuse me, there are two available medications of here. The first one is the one available only in on the US called dihydroergotamine, DHE 45. That's the one the most commonly used. Is available, and I think the only one is now used in the US. And DHE or dihydroergotamine is only available parentally. It's available as IV, IM, sub-Q, and intranasal. And in terms of efficacy, the IV and IM way superior than the sub-Q, and the sub-Q is way superior than the intranasal. The intranasal dihydroergotamine, it's very expensive. I've never seen it, but IM and IV ergotamine is very strong. The issue with IV ergotamine, it has to be under supervision because of that severe vasoconstriction. Another ergotamine is called ergotamine tartrate, rarely used because of very bad taste. These drugs are very bitter, actually even triptans. So all the intranasal formulations will have a very bad, unpleasant aftertaste because of the acidity. These medications are very alkaline. That's where the alkaloids come from. So these medications are very basic in terms of pH meters, and they will have a lot of taste issues. So all the nasal formulations of them, they'll just have very bad aftertaste. So they have the same contraindications as triptans. So definitely, absolutely avoid in cardiovascular disease patient, absolutely avoid in Raynaud's disease patients, absolutely avoid combination with patients taking other MAO inhibitors. In this case, you would maybe even more avoiding them rather than with triptans, and definitely avoid in pregnancy. And always should be used with the antiemetics because of a lot of GI side effects that the taste cause with these triptans, the taste of the intranasal, I mean, and should always be used with antiemetics. Now, last line option for very severe, if that patient is not responding, it's in the order set. The last line option is not last line options. Then you can go to ketorolac. You can talk about opioids later on. I'm talking just the treatment of the attack in the ED. You may give corticosteroids. And corticosteroids are usually added to standard abortive for only during severe or refractory attacks. Refractory attacks meaning get attacks lasting more than an hour or half an hour and not responding to triptans. Patients has to receive steroids. Corticosteroids here in this case is only given parentally. They have excellent efficacy. It used to be a single dexamethasone dose of 10 to 25 milligrams. It's a very super high dose. And the good news here is that now we're having more data showing that lower doses steroids could just do the job as good as the high dose steroid. So while the recommendation now is 10 to 25 milligrams dex, there are studies that shows that doses up to 4 milligram dexamethasone is actually producing good response. So you don't have to give steroids at such high dose, because steroids at such high dose, they will have hyperglycemia and they do have psychosis, not psychosis, they do have a lot of CNS side effects. Now, opioids and barbiturates, where do they fall? They are unfortunately still to nowadays, or at least to a year ago, they are the most commonly used abortive treatments, unfortunately, opioids and barbiturates. And, patients have pain. We think of opioids to be the best painkillers. Unfortunately, even as painkillers, they have less efficacy for aborting a migraine attack compared to triptans. And not just lower efficacy compared to triptans, they have very high rates of medication overuse headache. That's paradox of you taking a medication for a headache and you're ending up having a headache from the medication you're taking. And these medications should almost always be completely forgotten from the treatment plan, unless in severe cases where you have very severe pain and you want the patients and you want to calm the patient, and it's under control settings in the hospital as IV treatment, not as like a 2 tablets oxycodone kick in after an hour and the patient's having migraine. It just doesn't work. And it's all part of that overuse of opioids the past years. Now this has been controlled now. That's why we have ketorolac, we have ketamine, but it's still a big deal. Some providers unfortunately still use barbiturates and opioids for abortive therapies. While in fact they should be just as last line option if something, or if the patient's attack is severe and it's part of the treatment in the ED if the patient's screaming. But I'm not saying every migraine attack should have an opioid or a barbiturate. These barbiturates like Fioricet or Fiorinef or opioids, if they would be used, should be limited to maximum 5 days per month. So triptan were supposed to be, I think, limited. We said 10 days. Opioids and barbiturates, if they would be used, they should not be used more than 5 days a month, and doesn't have to be day by day. Now, until 2019, that's the story. That's ended. And you think is like, wait, hold on. We talked triptans, and we said if triptans doesn't work, you have ergots and steroids and opioids. But patients with severe cardiovascular disease can't have triptans. So what do we do for these patients? In the past, patients with cardiovascular disease do receive triptans under controlled settings. And again, it's all risk-benefit discussion. Severe cardiovascular disease, they won't, but mild, controlled hypertension, dyslipidemia, yeah, it's not that vasoconstriction is not. However, until 2019, we have the first drug that got approved for migraine after, I don't know, for like 15 years. And that drug called lasmiditan. It's an emergent treatment. It's a 5-HT1F agonist. So it's not a 1B, it's not a 1D. And that's 1F agonist lacks the vasoconstriction effect. It has only the anti-inflammatory effect, and it doesn't have the vasoconstriction effect. So what's the market? What's the market thing is that this made this medication to be the first FDA approved safe medication, theoretically safe in CV patient in which those with contraindication to triptans, severe cardiovascular disease patients can receive this medication, which is a very, very good point. This medication is super effective. It's an abortive treatment, so it's given as a single dose. So you get 50 milligram. I don't want you to no doses. I want you to know the dose as like single dose, but no strength. You give it as a single dose, 5-10 minutes, no response. You can repeat after 15 minutes. Side effects, in the clinical trial, it had a relatively high rate, almost more than 50% compared to placebo, but the side effects were well, I mean, there was a high rate, but they were mild. And these were dizziness, somnolence, nausea, paresthesia. So basically, the only warning exists for this drug is that patients should not operate a machinery or do a high executive function for about 8 hours after a dose, because the drug will be eliminated by then. So complete change of triptans from having cardiovascular agents to a drug that is safe, some side effects, and so on. Now, it's not only lasmiditan was approved in 2019, we have a new classes of medication. We call them GPANs. Now, these are small molecule CGRP inhibitors, which stands for calcitonin G-related peptide. From Dr. Ishmael lecture, you learn that the CGRP gets released in the early phase of the attack and excites the neural ending of the trigeminal nerve, and kind of begin the process of the pain. These medication, we have two medications that will target the CGRP. We have medications in the abortive treatment, which are the GPANs, and we're going to talk about different CGRP inhibitors in the prevention when I talk after the break. Now, the GPANs, These are abortive treatment. These are small molecules. Think about it. Small molecules goes to the brain really quick. It will cause terminate the migraine attack. These are oral agents, just like lasmiditan, for the acute treatment in patients with either insufficient response or contraindication. So the game here is always is that cardiovascular toxicity, which is not a big deal with triptans for severe cardiovascular is, but now it became an angle for new therapeutics, which is good. And this in this case are the gepants and the lasmiditan. So we have two agents. We have ubrogepant and rimegepant. These are both a single dose agent, single, and you can repeat within 2 hours. Their side effects are very well tolerated, nothing special, nausea, somnolence, dry mouth, no some haven't been compared to triptans, definitely. These are very new, but still expensive, yet good agents, good alternative to triptans. I am interested in comparison, but we don't have this so far. And that's it all for abortive therapy. Now we are right at time, so I will give you a break. When we'll return, we'll continue the preventive therapy and we'll talk about cluster headaches. We're almost halfway through. Any questions? Well, no questions. Let's come back right what time is it now? At 1 p.m. Oh, there is a question. Does food containing tyramine trigger migraine? Yes, that's why I had very good. That's why I had alcohol. I had alcohol, which is wine, chocolate, and cheese. Yes, can trigger migraine. Yeah. Does L-tryptan have serotonin syndrome risk? Theoretically, it has. All of them, they have that warning. That serotonin syndrome is going to be for all. Yet it does look like, and it does say that L-tryptan, as well as Frova and naratriptan, are the least likely to have serotonin syndrome. Again, all triptans have that blanket statement warning. However, I said in evidence, that risk is almost very rare. Now, in terms of kinetics, elatriptan, Frova, Nara should have the least. Yet FDA says put the label, but we know it's, just by epidemiology, not by kinetic studies, these are not that risk. For the exam, would you say anything in red is what expected to know? I mean, yes, anything in red, pretty much what I'm talking about, anything that has to do with therapeutics. I think you're familiar with my exam. I always give a question about a drug or a case, and I will ask, which of these triptans are subcutaneous, which of these abortive agents are safe in cardiovascular patients. I only have 40 slides, and I hope my slides are not big. So yes, the red ones are the important, but I don't have a lot, and I hope you consider pretty much the whole topics, except for strengths and percentages. Definitely, these are not important to memorize. Put your questions in the chat, and let's come back in 7 minutes. That is offered but not limited. I say so that on theory is that those who have more than 4 attacks per month, again, you don't need 4 attacks per month. It's usually, again, it's not just quality, it's not just quantity, it's quality. So severe disabling attacks, or anyone who can't take the abortive treatment options. No, before the lasmiditans and the gepants, which are new drugs, not tested yet for pregnancy. That's why I didn't have any information. As you know, that pregnants are often excluded from these phase 3 trials. So we don't know about these medications safety in pregnancy, and therefore for patients, for example, a pregnant female can take abortive therapies, maybe take acetaminophen, and offer preventive therapies. What are the goals of preventive therapies? While we do call it preventive therapies, it's never prevented 100%. an idea of a good response for a preventive therapy is 50% reduction of attacks per month. So that's the criteria clinical trial use for evaluating drugs for migraine prevention. It's not reduction in the attack, it's 50% reduction in the attack. So that's the goal. That's what we call, well, not cured, but that's what we call controlled migraine, is a migraine that is almost 50% less in frequency. And definitely with that comes improving functions and reducing disability, because as you know, the morbidity of migraine is not just the pain, is the missing work, missing missing studying, missing taking care of normal responsibilities. It has a lot of financial and social as impact as well, and preventive therapy should help mitigate that issues. No, preventive therapies has nothing to do with oral therapies. And while abortive therapies, and while abortive therapy may have made sense in terms of mechanism, so antiemetics, vasoconstrictors with the triptans, preventive therapies there is no certain mechanisms, only effect with the last class. It's almost every brain medication have been tested for migraine prevention. If you look to the charts of suggested, there are tables of the drugs that are recommended, which I'm summarizing here in my slides. There is a table of drugs that are not recommended for migraine prevention based on poor data, and almost every drug you can think of has been tested, not exaggerating, but a lot of medications has been tested for migraine preventions, and they all have not very good results. But those who have good results, by good results is 50% reduction in attacks, are the ones I'm going to talk about. So most commonly used are beta blockers and calcium channel blockers. So cardiovascular medication, beta blockers, heart rate, calcium channel blockers, also heart rate. You can argue that verapamil is even maybe somehow vasodilator effect. They work. How? Well, that's the beauty of medicine. It's just they work. So beta blockers and calcium channel blockers, metoprolol is very common. Propranolol, it's FDA approved. Atenolol. See, I put these two. They used to think that lipophilic beta blockers, those can go to the brain like propranolol. But atenolol works, and atenolol is 100% hydrophilic, 100% renally eliminated, doesn't cross the blood-brain barrier, yet it works for migraine prevention. Verapamil, excellent drug for migraine prevention. Antidepressants, of the antidepressants is SNRIs, venlafaxine is excellent for migraine prevention. And to a lesser, amitriptyline, tricyclic antidepressants, also work, but they have high incidence of side effects, as you know, and I'll go one by one. Anti-epileptics also used as kind of a last line agents. These are valproic acid and topiramate. Topiramate is FDA approved for migraine prevention, but these medications are anti-epileptics and they will have special side effects. And finally, the last medication that has an understood mechanism of action are CGRP antagonists. But in CGRP antagonists, I told you they come in two flavors. They either come as monoclonal antibodies, so these are biologics. And when I say biologic medications, means that they are never oral. They have to be injectables. And notice the MAB, monoclonal antibody, that's the MAB ending. So all of these are iranimab, fermanezumab, and the other one, I don't know. And now there is another one. I think there are 4 now monoclonal CGRP inhibitors. Also, the small molecule CGRP, urogepant, has been tested for migraine prevention as well. Now, principles of preventive therapies, regardless of the drug you choose, these principles are applies to the success of migraine prevention, is that whatever drugs you're going to use, and I'll go on details for these medications one by one, you always start low and go slow, whether verapamil, whether an SNRI, whether valproic acid, with the exception of these they come in pre-filled syringes and they have fixed dosing. But start low and go slow. I'm talking about the classic agents that we use for migraine prevention. Opioids and barbiturates. In fact, any of the medication that use for abortive therapies should never be used for acute, for preventive therapy. So no triptans, no barbiturates, no opiate, no NSAIDs. They should be used just as part of painkillers, but they are not for prevention. They're for abortive treatment. Now, women of childbearing potentials should be and must be this if she has a migraine, chronic migraine, should be warned about the potential use of anti-epileptics during pregnancy, as you know. And those who are, well, most of you there, what's the issue of anti-epileptics with pregnancy? What vitamin is most likely to be affected with anti-epileptics exposure in pregnancy? Please put that in the chat. I'll give you a minute. Now, anti-epileptics are big classes, but they all share an issue for pregnancy, which did you study seizure? That I don't. Folic acid, yes, yes, thank you. Folic acid, specifically what valproic acid do, what carbamazepine do, what phenytoin do, most anti-epileptic benzodiazepines is that they interfere with the metabolism of folic acid. Folic acid is an essential vitamin, means that our bodies can't synthesize it. We have to have it from diet. If you are low on folic acid, well, as you know, it's for a woman trying to get pregnant, they have to be supplemented with folic acid. This will cause neural tube defects, so which we call a spina bifida, opening of the spinal or improper closure of the neural tube in the first trimester. And therefore, women of childbearing potentials who will take preventive therapies should have a discussion about the possibility of anti-epileptics therapies and the effect of pregnancy. Again, address the patient expectation and preferences, of course. The nice thing about having so much choices with these medications is that we can choose the one that most likely that the benefits the patients, and the patients may have comorbidities, so you will give it according to that. So in general, there is no single preferred agent or a class. There are no head-to-head data, or head-to-head are very low quality. And your agent selection is very easy, should be based on tolerability, cost, comorbidities. And I think comorbidities are almost always a good argument for choosing one agent over another. So what kind of comorbidities? So if your patient is a cardiac disease patient, you're most likely to be preferring beta blockers or verapamil over the other agents for a prevention. If your patient have psychiatric diseases, and that's not just depression, anxiety, post-traumatic stress, and so on, panic attacks, you can prescribe venlafaxine for the CNS symptoms as well as for migraine prevention, or amitriptyline, second line, tricyclic antidepressant. So much side effects, you prefer venlafaxine before. Notice there are no SSRIs. SSRIs don't work only for depression and psychiatry. They don't have, just like, we use duloxetine for neuropathies, but you can't use fluoxetine for neuropathy. So no SSRIs, just SNRIs or amitriptyline. If you have epilepsies, then valproic acid or topiramate. These are anti-epileptics of choice for patients for migraine prevention. If you have obesity, now that's before the new drugs. If you know Qsima, topiramate, Qsima is an FDA-approved product for weight loss. It's half topiramate, half phentermine, which is an amphetamine. And topiramine causes weight loss. So obesity, I'm not saying topiramate will be the first-line agent for obese patients with migraine, but I say there's an argument to consider for obesity and topiramate. But topiramate is not an easy, it's an anti-epileptic drug. It's not a simple medication, so should not always be your first line. If you have Raynaud phenomena, which is a vasoconstriction of the extremities, then you just need a vasodilation, and that in case verapamil will be your agent of choice. And this is what you are responsible. I may give you occasions of having something here and ask you to give the best preventive agent. So for beta blockers, metoprolol and propranolol are the most commonly used agents. Dosing, I don't want you to memorize dosing. I just want you to know that the dosing is usually less than the hypertension dose, which is a good thing. However, when you taper it up, you may end up in the hypertensive dose. And even if the patient doesn't have hypertension, that beta blocker is not an issue. They won't have hypotension. Response usually takes a month. All of these drugs, we're talking migraine prevention. So in order to witness a response, you're gonna have to wait at least a month. And if you want to evaluate full, it's 3 months trial or three months trial for each drug. Now, side effects, these are side effects of beta blockers. That's what makes it simple here. So side effects, erectile dysfunction, Raynaud phenomena. Bradycardia is a big contraindication. So if you have an elderly patient with low baseline heart rate, forget about beta blockers and forget about verapamil as well. Caution with asthma, with diabetes, with patient with depression. Calcium channel blockers. So as you know, we have two types of calcium channel blockers, the non-hydropyridines and the dihydropyridines. The ones we're talking for migraine here is only verapamil. Diltiazem and amlodipine has been tested, but they have been shown not to be effective. Verapamil have the best data for migraine prevention between the CCBs. Dosing, again, it's multiple time per day dosing, but you don't need to know. And oftentimes you may reach, again, high doses. Unlike beta blockers, CCBs have vasodilatory effects. Doesn't really mean anything in terms, not even related to that vasoconstriction. Now, I'm sure some may think, oh, vasodilation, wouldn't that precipitate the migraine attack? Didn't you tell us vasodilators can trigger migraine? I'm talking strong vasodilators like nitroglycerin, not like vascular vasodilators. And verapamil doesn't have a big vasodilation as a medication. It's just in comparison to beta blockers. Now, what's the side effects of verapamil? Constipation is a big deal with verapamil, and consider this is a daily use medication, so there's an issue. And this is a CCB, so just like beta blockers, bradycardia is an absolute contraindication. These medications lower heart rate. Should never use a CCB in patients with reduced ejection fraction heart failure, so HFrEF. Patients with reduced ejection fraction heart failure. And verapamil has a lot of drug-drug interaction. It's one of the strongest CYP3A4 inhibitors. Now, antidepressants, we said SNRIs and amitriptyline are the most widely used in practice. Within the SNRI, venlafaxine is almost always, and it's always start low, go slow. Doses, again, you don't need to know the doses. But something with venlafaxine is that you should remember it's an SNRI. So serotonin, norepinephrine, reuptake inhibitor. Serotonin is okay. That norepinephrine reuptake inhibition, it looks very common at high dose. And because of that high dose venlafaxine have a dose-dependent increase in blood pressure. The higher the venlafaxine dose, the more likely you switch from serotonin to norepinephrine reuptake inhibition, and that will lead to kind of a dose-dependent increase in blood pressure. Other than that, sexual dysfunction, just like SSRIs, venlafaxine is very well known for that. Amitriptyline is not really preferred because of the side effects. This is tricyclic antidepressant, so it has to be given at bedtime because of the sedation. And as a TCA, it has sedation. That's an antihistaminergic effect. It has tachycardia and QT prolongation. That's poisoning. Weight gain, orthostasis, which is orthostatic hypotension, postural hypotension. This is alpha-1 blockade, and anti-acetylcholine, anticholinergic side effects. So dry mouth, cycloplegia means pupil dilation, blurry vision, constipation, and urinary retention. Now, the anti-epileptics are highly effective. These medications are super, super, super good medications for migraine prevention. The only issues is that they are not first-line agents because of their side effects. I mean, they're anti-epileptics. These medications don't even make it, like valproic acid doesn't even make it as a first-line agent for epilepsy because because of the side effects it has. So these medications, you see everything red with their side effects because of their basically bad toxicity. So topiramate, because I mentioned weight loss, it's even FDA approved for weight loss under the name Qsema or Qnexa. Topiramate causes nephrolithiasis, so kidney stones, cause paresthesias and cognitive impairment. Topiramate's brand name is Topamax. And some providers, I know they like to call it Stupomax because of so that they can remember to counsel their patients on the cognitive impairment. So decrease cognitive function, decrease reduction in IQ. It's reversible, and it happens when you taper the topiramate very quick. That's for topiramate should be tapered on every 2 weeks basis, not even every 1 week basis, to avoid that cognitive impairment. As for valproic acid, the side effects are crazy. This is one of the most common medication that it's one of the most effective medication for epilepsy and for migraine. But the side effects of it is too much. So it's caused weight gain, it's caused low platelets, increased risk of bleeding. It's one of these few drugs that are known to cause pancreatitis, inflammation of the pancreas, and this is an ICU case. Hypertriglyceridemia, transaminitis, increased LFTs, liver damage, alopecia, and not on top of that, it's a very potent CYP inhibitor. So, and the pregnancy concern. So, absolutely, this medication should not be considered as for migraine prophylaxis in females or childbearing potential, especially if they haven't tried the beta blockers and so on. Now, finally, or almost before the finally, are the CGRP inhibitors. So these are, again, as I mentioned, the new medications, and they come in there are two variations. There are the small molecules, and small molecules are better for abortive, or they were actually designed for abortive. And there are the monoclonal, the biologics, the protease agents. And these are the ones I'm talking about. So in 2019, we had 3 CGRP got approved for refractory migraine prophylaxis. And in 2022, we have another one. And I think in 2022, we had another one. So I think totally we have 5 now. What's the issue is that we don't know much about them. They're still new and they are being used. They are safe and effective. By safe, I mean they don't have any of the side effects I mentioned with the beta blockers, with the CCBs, and they don't have any, and they are effective. They have been reducing compared to placebo. They have not been compared to anything else but placebo. They are theoretically safe in cardiovascular patients. They were excluded from the studies, but there was no signals in the safety reviews that this medication could have any cardiovascular issue. There is just some concerns about some, cardiovascular, pulmonary, psychiatric. Few cases of angioedema and hypersensitivity have been reported, but more data has not been, and it's been only 2 years. It's not been long enough to know the full safety, but this medication so far looks to be very safe. The only issue for these is that the cost. Notice these are all monoclonal antibodies, so they have to be injectables. You can't give a protein, it will be dissolved in the stomach. So they are injectables. They are a monthly or every 3 months injections. They are pre-filled syringes, and they are pretty much expensive. Not too crazy expensive, but they're definitely more expensive than the beta blocker, which are 10 cents per tablet or so on. We have one more CGRP that's called rimegepant, and rimegepant has been approved for acute migraine treatment, and is being studied for migraine prophylaxis. So the same medications as these. It's not monoclonal, it's a small molecules. Notice the name is different. And it's because it's small molecule, it's oral, it's given daily prophylactic dose of 75, sorry, not daily, every other day. This is just in clinical trial, have not been shown. There is no much real practice with this medication, but it has been shown when compared to placebo that it does work for prophylaxis. It's almost associated with pretty much 10% absolute risk reduction to placebo. So when we talk about 50% reduction, so really, really exciting stuff and good stuff for migraine prevention. Now, the last thing or the last couple of things before cluster headaches I'll talk about is Botox or botulinum toxin. It's been used a lot. I think there's a question in the chat. For all these preventive therapies, will patient have to take forever or only for a certain amount of time, despite patient or might not have comorbidities? Good question. In theory, it's not forever. but it will be at least 6 months to a year basis treatment, and you evaluate. Generally treat for at least 6 months, just like when you treat for depression. Treat for at least 6 months and evaluate response. Evaluate, or I was saying prevent for 6 months. You can consider taper down. If you see from my slides, I think it was supposed to say dose reduction upon improvement. Whenever you reach, you don't put the patient again. You will always want to challenge with dose reduction, and if the patient responded well to dose reduction, you may even consider discontinuation. So it's a patient by patient case. And thank you for your question. It should never be a chronic, but it will be long-term use with consideration to discontinuation if there is a response, definitely. As for Botox, so it's very confusing. I just want to give you the gist. There is no like information here. I just want to know how to answer a Botox related question for migraine. So there's a lot of RCTs, and they found all types of Botox, not just Botox, all types of onabotulinum toxin to be ineffective for episodic migraine prevention. So this is a this is a migraine prevention, but uh, it's called an episodic migraine. We didn't talk about it. It's that type of chronic migraine, but it doesn't happen all the time. It happens in episode, meaning that there are less than eight attacks in less than eight headache attacks months. Uh, and the idea is here is that uh, Botox have not been shown to be effective in this type, which is called episodic migraines. However, some other studies found it to be effective in chronic migraine prevention. So this is, again, what's the difference? They're both types of chronic migraine. I'm not talking about abortive of prevention. We're still talking about prevention, but episodic migraine prevention is a migraine that doesn't have as common as the chronic, and there is no like a don't know how to say. There's no agreement of how many, what's the frequency cutoffs. What the issue is that the bottom line statement is it's confusing for Botox, and many neurologists still use it as a last line agent, especially if these agents, the G-PANs, are unavailable and the patients have exhausted all their agents. As for contraception, is a very, very big deal. As I mentioned, this is a now this could, we could have a special lecture on just migraine and contraception, epilepsy and contraception, depression and contraception, because it's all these medications are not safe in pregnancy. So what do we do? So and here I'm talking about the oral contraceptives here, is that there is a blanket statement that oral contraceptives may increase the risk of stroke in patients with migraine, and this is real. Now, the issue with this incidence, with this finding, is that these were observational studies and they were using old oral contraceptive pills, meaning they had estrogen doses equivalent to 50 microgram daily. Now, 10 years after 10 years ago, we have no more estrogen that comes in 50 microgram. The highest estrogen dose in the market as a contraceptive, I think it's 30 micrograms. So that finding of contraceptive causing strokes in migraine patients were patients taking the high estrogen that we never you have anymore. Now, what's the recommendation? Is low estrogen safe? We don't know. Maybe. What's the recommendation? Some registration childbearing potential, if they want to use contraception and they have migraine, is better to use a progestin only, what we call a mini pill, or something like an IUD or a progestin implant. So yes, estrogen do cause the stroke. However, that finding again with the 50 microgram, which are no longer in the markets, and all the estrogen products we have are low dose, yet the recommendation still stands, and rightly so, to use only progestin related products to avoid estrogen. Now, the last thing is cluster headaches, and I think I only have 3 slides on this one. Same medication, nothing much, it's just different therapeutics, but same approach as migraine. Just a review of cluster headaches. You have the photo here, but it is also a unilateral, just like migraine. But migraine was half the head, vascular in nature. Cluster headache is unilateral around the eyes, near the nose. It has a lot of association with sinuses, that cluster headache. And cluster headaches affect males almost 6-1 to females versus females 3-1 in case of migraine. Now, the symptoms are very important of cluster headaches. They call it the icicle pain. Patients often describe cluster headache as if having an icicle or a piece of iron through the eye. That's how much painful cluster headache is. It's a severe pain with redness around the eye on one-sided pains associated with excessive tearing. It's a lot of tearing and a lot of stuffy nose. So there's a lot of sinuses and there's a lot of tearing going on. Patients have facial sweating on the affective side of the degree of pain, and definitely the patients will have flushing from that congestion. How is the presentation? It's very bad pain. It's worse. It's the worst headache ever. Well, the worst headache ever is a hemorrhagic stroke headache. So I won't say that, but well, it's different, but it's a worst primary headache pain, let's call it, because hemorrhage in the brain causes the worst headache. They call it thunderclap headache. Cluster headache is also of the same severity. That's how much bad. Patients with cluster headaches don't come to the pharmacy. They go to the hospital right away from pain. Sudden onset, excruciating, stabbing quality. That's why I told you it's like having a knife coming through the eyes. It's unilateral with facial pain. It's attack, and it's called, it comes in clusters. So it's short attack. It comes in, it goes, it comes in after it goes, and it can stay for up to 90 minutes. Migraine can stay up to days, and it occurs during the night, and it occurs in clusters. It comes weeks to months and then goes away and then comes in weeks to months. So in 1 month, you can have a cluster of up to, sorry, in 1 day, you can have up to 8 attacks a day in clusters. So in half-hour period, you get cluster headaches. It goes, it remain. It's very, very painful. Unlike migraine, which migraine have higher risk of stroke, cluster headaches typically doesn't have any long-term consequences except for the pain. What's the treatment? Acute and preventive. So we have acute treatment and we have preventive treatment. Same rules. For acute treatment, your first line agent has to be oxygen. Oxygenation removes the pain significantly. So you have to give oxygen. That's why it's a hospital admission. You have to, it's in the ED, almost 10 liters of O2 of oxygen per minute in a face mask by a non-breathable face mask, plus the triptan. So the same triptan you used for migraine, you can use it here as abortive therapy. The sooner you give the triptan, just like migraine, the better the response. So oxygen plus triptans, ergotamine should technically second line should not be used. Lasmiditan and the G-PANs have not been tested for cluster headache. It's not very common cluster headache, but again, same rules for triptans, injectables. And same thing, also you can give antiemetics with it. Second line agents you didn't learn on migraine, there is intranasal lidocaine, so a local anesthetic via the nose. Doesn't really work, but it's a good agent to add for a triptan if the patient does not respond to triptans or have contraindications to triptans. You can use intranasal lidocaine. As for long-term treatment, generally speaking, cluster headaches has to be prevented because it comes in cluster, it's unpredictable, and it's always severe. So all cluster headache patients somehow are offered prophylaxis, and there are 2 drugs very well studied. One of them is verapamil, and it is the drug of choice. Now, verapamil used also for migraine wasn't a drug of choice, but for a cluster, it is the drug of choice for a prophylaxis. 70% get respond after 1 week. A bit higher doses than the migraine and the hypertension. You don't need to memorize it, and that high dose will require some heart rate monitoring. As the other agents for prevention is not, we didn't study it with for migraine, is lithium. So you studied bipolar, you studied lithium. You know how this drug doesn't make sense, yet it works beautifully for mania, and it works really well for cluster headache prevention. Just like verapamil, the effect can be seen very quick within a week, unlike the migraine prevention, which is a month. Uh, Again, I'm not gonna talk about dosing, and I'm not talking about but technically you want to use lower dosing than bipolar, makes sense, than bipolar patients, and you target a lower serum concentration. If you remember from your bipolar, the target lithium is just like your serum creatinine, so zero point 0.8 to 1.2 mec per liter, of course not milligram per deciliter. So if you remember, the cutoff for lithium toxicity should be between 0.8 to 1.2, just like serum creatinine, if you want to remember. And for patients with cluster headache prevention, they need a lower cutoff, so less than 0.8. I don't want you to memorize lithium, but if you know lithium, you should know, because lithium is a very, very big and difficult medication. I urge you all to review it. In P3, you will deal with lithium in P3 with me as well. But just remember, should never be used in pregnancy. Lithium, it's a cation, so it can cross the placenta like no other. You have to monitor serum creatinine. You have to maintain hydration. You have to avoid electrolyte abnormalities. Patients on lithium gets monitored with lithium level every month. But this is all what I have for migraine therapeutics. So some typical home messages. Migraine is common and highly morbid. Migraine attacks are often severe, associated with sensory and or motor dysfunction. Of course, attack alleviation and prevention of future attacks are the goals of treatment. Abortive therapy is offered for almost all and acute, and it should be given as soon as possible. Should be parenterally for a triptan, preferably for severe attacks. And it is also almost always co-administered with a parenteral antiemetic. All triptans are equally effective, but consider Frova and Nara to have slow onset and have least likely interaction with MAO inhibitors. The antiemetics should be all parenterals. They are combined with the triptans. They have equal analgesic or additive analgesic effects. Whenever you give an antiemetic IV, you should give diphenhydramine also as IV. We call this the migraine cocktail to prevent the dystonia and other extrapyramidals. And don't forget your patients to be on monitors if they are taking compazine or prochlorperazine or metoclopramide, any of the antiemetics agents, if your patient at risk of QT prolongation. Definitely barbiturates and opioids should be not considered for first line agent, not even second line agent. Parenteral corticosteroids is reserved for severe attacks, that you should consider that. As for prevention, we talked about who is the patients are offered, and agent selections for both cluster and migraine for prevention should be in table 20, slides 23. Also, the final two slides on cluster headaches for prevention therapy. Well, ahead of time, I had no doubts with the migraine lectures. I'm happy to take your questions. Well, as I wait for your question, feel free to put it in the chat, to email me. You have my email. This is all for our lecture today's. You're welcome to leave. I will stay extra if anybody has a question. But other than that, it's been a pleasure. I wish you all great luck, great success, and yes, finals week coming. Best of luck, everybody.